Okay, welcome to the Birth and the Newborn PowerPoint, Chapter 3, and we're going to be covering birth and the neonate, which is also the newborn, and caring for newborns. Okay, so just a few disclaimers as we get started. Again, I often will use that you as I'm talking like you are giving birth, and I know not all of you will. And also I will sometimes default to mother, she, her, even though I know that someone could be female giving birth but identify as a he or a they or a father or more gender neutral. And then lastly, I'll continue sometimes to give you too much information, maybe some gory details you didn't want to hear but I think might be important for everybody to know. Okay, so childbirth is divided into 3 stages, first, second, and third. Here we're going to be talking about the first stage. And right now we're talking about traditional labor, vaginal delivery. We'll later talk about C-sections. So in traditional labor, the first stage is the longest stage. It's about 12 hours for your first birth, and on average, about 6 hours for later births. And so the placenta and the uterus secrete prostaglandins, and these then excite the uterine muscles, causing contractions. And these contractions then efface and dilate the cervix. And the cervix is the opening at the bottom of the uterus and the top of the vaginal canal. And during pregnancy, it stays tightly closed, and there's even a little mucus plug in there to keep it all kind of tightly closed. But as you're preparing to give birth, the cervix has to dilate, which means widen. It has to go from 0 to 10 centimeters before you can push a baby out. And then it also has to efface. The walls of the around the cervix have to open, and that's thinning, and that is by percentages. So they'll say something like you're 20% effaced or you're 90% effaced. And so before they allow you to push a baby out, they want you to be 100% effaced or very close, and 10 centimeters dilated. Okay, so the first stage of labor is then subdivided into early labor, active labor, and transition. And so early labor usually happens at home, even if you're planning on delivering in a birthing center or a hospital. And so usually medical personnel don't want to see you in early labor. This is when your cervix is less than 4 centimeters dilated and your contractions are irregular and more than 5 minutes apart. Once you start having fairly regular contractions 5 minutes apart, then if you're going into a birthing center, assuming you're not doing home birth, which we'll talk more about, then it's time to go in. And once you get checked in, they always check you. A nurse or a doctor will always check. And so this is a fairly invasive thing. They basically put their hand up inside your vagina and they use their fingers to figure out how dilated your cervix is and how effaced you are, and then they will pronounce that. And that's going to happen a lot during the delivery process, where someone is checking and pronouncing your dilation and your how effaced you are. So then you move into active labor. And so here you are, maybe in a birthing center in a hospital, and at this point you have the choice of an epidural, and we're going to talk more about what an epidural is and some of the pros and cons. You don't usually you don't get an epidural in early labor, and by the time you get to transition, it's too late to get an epidural because it has to be ordered through an anesthesiologist, or has to be put in an order. An anesthesiologist has to come and deliver it, and so it's not something that usually happens very quickly. It takes maybe 45 minutes or an hour to get it going. So active labor can be hours, right? And then once you move out of active labor, where the contractions are coming fairly kind of regularly in predictable ways, then you move into transition. And transition is very intense, whereas the contractions were coming every few minutes and, kind of fairly predictable, and transitions, suddenly it's very rocky, and they contractions can be coming kind of one on top of the other. Transition is typically more around 30 to 45 minutes, but it can be, hours, and obviously that would be excruciating. And so that's all happening before we get to the second stage of labor. Okay, so let's talk about who are the healthcare providers in the birth process. So both obstetricians or OBGYNs and family practitioners are medical doctors or MDs. OBGYNs are trained specifically in the birthing, pregnancy and birthing process, and can, are often the ones to handle high-risk pregnancies. Family practitioners less likely to handle high-risk pregnancies. And then midwives have a wide range of training. Some can have more advanced certifications than others, and they can be providing their services. They can be delivering babies in a variety of locations. Doulas are not technically a medical professional or healthcare provider. They're more like birthing coaches that are used along other healthcare providers, and their purpose is to help people have really empowering, kind of safe, memorable birth experiences, to be advocates for them. We'll talk a little bit more about doulas. In terms of locations, hospital births are by far the most common in the United States, followed by then birthing centers, and then home births, which are fairly rare in developed countries, even though they're very common around the world. So in developed countries, they account for just over 1% of all births. In hospitals, your birth could be attended by an OBGYN, a family practitioner, a midwife, and a doula as a coach. Hospitals have pros and cons. So it is the safest option if you're high risk. You have immediate access to, C-sections if needed, kind of fetal monitoring, pain medications and interventions, oxygen if you or the baby were to need it, drugs to kind of control any hemorrhaging. The cons are that it's more expensive, it's more impersonal, it's not as flexible, and it's geared towards medical intervention. And so you could find yourself just having more kind of medical interventions or small interventions than maybe you would otherwise. And of course, it depends on who's on staff and, how kind of skilled and busy or overwhelmed they are. A new study by CSU researchers found that the quantity of delivery complications in hospitals is higher on nights, weekends, and holidays. So, you might be getting higher quality care Monday through Friday during business hours than you would be during off hours. So let's talk a little bit more about epidurals here in the active stage of labor. So again, epidurals are usually given in the active stage of labor, not early or transition. And they're given via a catheter into the epidural space next to the spinal cord. So it's an anesthetic that can provide amazing pain relief. And it's also important to know, which I didn't know, when I had an epidural, that epidurals can vary in dose. So just like any anesthesia, you could be given a kind of a lighter dose where you might still experience some pain, medium dose where you can still experience sensations, or a really heavy dose where you are completely numb and experience hardly anything. So more on that in a little bit. I do want you to know that I'm biased against epidurals only because I had a negative experience with one in my first pregnancy. And so it'll be important for you to investigate kind of what the research says on epidurals when the time comes. But so epidurals have the pro of providing pain relief, which is huge, but they are correlated with a longer stage of labor for some people. And so that's the second stage of labor, which we haven't talked about yet, which is the pushing stage. So epidurals can make pushing more difficult. They can also lead to an increase in fetal heart rate variability. So the baby's heart rate is always being monitored, in hospital settings in utero, and it can lead to the heart rate seeming kind of too low or too high. And it is correlated with later increased use of forceps, which we're going to talk about, or vacuum extraction, which we're going to talk about, to pull a baby out. Basically, it can be harder to push a baby out, and then you are more likely to need intervention. And this is what happened to me in my first delivery. Is I think I had a very heavy epidural dose. I really couldn't feel anything, and I had a very hard time pushing my son Isaac out, and he experienced some heart rate, kind of fetal distress. And so they ended up pulling him out with a vacuum extraction, and he initially was fine, but then about an hour after he was born, he had a hypothermic response. He turned blue, he stopped breathing, and they had to rush him into the NICU and revive him, and he was there for a couple of days. And then I feel like that NICU experience led to some other challenges for him later on in terms of some sensory processing issues. So I learned after that epidurals can vary in dose. And so if you're considering having an epidural, I think it's worth talking with your doctor and the anesthesiologist about the dose, and consider going with a light dose where you still experience some discomfort, but you kind of retain your ability to kind of work with the contractions and push a baby out. So research on epidurals and breastfeeding is more limited, but epidurals do seem to influence the hormones that are associated with breastfeeding, and they can basically slow down the breastfeeding process, maybe delaying kind of the milk coming in, or making it more challenging for babies to latch on. Okay, so now we're on to the second stage of childbirth, which is the one we always think about when we think about childbirth, which is delivery. And so this is usually between 30 minutes and 60 minutes. It's considered the kind of pushing stage, but of course it can be shorter if it's your second, third, or fourth child, or it could be quite a bit longer if it's your first child. And again, it's recommended that you're not pushing until you're 10 centimeters dilated and fully effaced, because otherwise it could be damaging to a mother's body. So sometimes you're feeling the urge to push and they're telling you, no, you can't push yet. So this is also when you could end up with an episiotomy, and episiotomies are painful to talk about even, but episiotomies are a cutting of the perineum, which is the tissue in between the vagina and the anus, and this is tissue that can tear during the birth process as a baby comes out. And so it was thought that if we could cut it, we could maybe control the direction of the tear and make it tear, of course, down towards the anus instead of up towards the urethra. But now it's becoming more controversial. Episiotomy rates are declining and varying because it can take longer to heal from an episiotomy than it can for just maybe the normal tearing that would occur. And so now there's maybe more emphasis on even peritoneal, I'm not sure if I'm getting that right, perineal massage, where you kind of try to stretch that the vaginal opening in that tissue to prevent it from tearing. Okay, but there may be some tearing or there may be an episiotomy. It really depends more upon the delivering physician, whether or not that's their practice. And then the baby's head comes out. That's called crowning, when you see the baby's head, and then one shoulder and then the other shoulder, and it usually happens over a series of contractions. So the baby's head comes out in one contraction, and then maybe in the next contraction, shoulder, and the rest of the baby. You often maybe have seen on movies how then the baby is placed up on the mom's chest and the umbilical cord is clamped and cut. And just very recently, the American College of obstetricians and gynecologists have now been recommending that you wait at least 30 to 60 seconds before you cut the umbilical cord. And this allows more blood to return to the newborn after the birth process, because while the baby was being pushed out, the blood was basically being pushed kind of out away from the baby, and letting this blood kind of return back in through the umbilical cord delivers extra iron, which promotes the baby's brain development. Okay, and so then we get into the third stage, and this is something that is never talked about, that I have hardly heard anything about, and never even heard about like in a Lamaze class. So the third stage is where you basically have to push out the placenta and the amniotic sac, and we talk about those as if they're the same thing. But the placenta is a pancake-shaped organ that's attached to the amniotic sac. So this is all the house of the baby. So you remember from prenatal development, the uterus obviously stays in the female's body, but the placenta and the amniotic sac, which was the house built inside the uterus, that needs to go ahead and come out. And this is maybe the size of, it's bigger than a softball. It's maybe the size of a mini watermelon, right? And it's basically like giving birth to a giant slug, but no one has prepared you for this. And if you were having to do this without having given birth to a baby, it would be terrifying. But after pushing a baby out, it's not that big of a deal. However, nurses will, you think you're all done and everything's fine, and yet a nurse is taking her fist or his fist and pushing it into your abdomen because they want to make sure that kind of all the tissue comes out, and it's kind of painful, and then they're making you kind of push with the last of the contractions. And then what happens at the very end, while you're maybe hopefully holding your baby and everything's going okay, is that, there's often a physician kind of down there stitching up any tearing in the perineal area, between the vagina and the anus. And so you're just kind of chatting away holding your baby, and somebody's stitching up your, perineum. And again, if you hadn't just had a baby, this would be a traumatic event, but whether or not you've had an epidural, you generally don't even hardly feel a thing. Okay, so let's talk about C-sections for a few slides. So rates of C-sections or cesarean sections are fairly high in the United States, and C-sections can happen in a couple of different ways. It can be a scheduled C-section, where the mother never goes into labor, but she just shows up at the hospital for her cesarean section surgery. Or C-sections can be an emergency C-section where you have been in labor planning to have a traditional vaginal birth, but something doesn't go well, and so then you have a C-section. C-sections also vary in whether or not they are kind of medically necessary or if they are out of convenience. And so certainly medically necessary C-sections have saved lots of babies' lives and mothers' lives. And so C-sections are often performed if the mother has a small pelvis for the size of the baby, they can be performed in an emergency fashion if the mother's unable to push the baby out, or the baby's in distress, or the baby is what's called breech, which is feet down instead of head down. If there's a known infection in the birth canal, then a C-section is planned. And C-sections are typically used for multiple pregnancies, so twins or triplets. But there are also reasons why people do it out of convenience, and that's more controversial. There's a lot of benefits to having a scheduled C-section. The reasons why people like to have C-sections are, first, when it's scheduled, you know when it's going to happen. You can plan around it. You can have the people there that you want to be there. The nice thing about scheduled C-sections is they generally don't happen in the middle of the night or on the weekends. They're during business hours when everybody's happier to be at the hospital and more alert. They also prevent, any kind of basically tearing or stretching of the vaginal and perineal region. And so some women really like that idea that their bodies will kind of be more pristine or intact. So yeah, those are kind of some of the reasons why people might choose it for convenience, avoiding the pain of childbirth because you're just anesthetized, general anesthesia for a surgical procedure. So it is controversial. We'll talk more about kind of some of the health risks of C-sections on the next slide. I do want to also mention this idea of what's called VBAC, or vaginal birth after cesarean. So typically once you had a cesarean, you were always going to have a cesarean because going through labor could put too much stress on the old kind of incision site and could cause tearing, was the thinking. And so it was not just a doctor's decision, it was actually a hospital-wide policy whether or not a hospital would perform VBACs or not. And many hospitals would not perform a VBAC. But now that's changing. And so sometimes people are able to have a VBAC even though they've already had one cesarean. Let's see. Okay, so this slide shows kind of some of the health risks associated with C-sections over the long term. So obviously in the short term, C-sections can really save lives. Over the long term, there are increased risks of obesity. So it's about 1.3 times. So it's not a huge increase in risk of obesity, but it is present. Increased risks of asthma, juvenile arthritis, IBS, other immune deficiencies, or leukemia. Mixed research on diabetes and celiac disease, some research showing increased risk, some showing not. Some people have suggested that one theory for why babies who are born for C-section might struggle is that they have fewer, because they don't come through the vaginal canal, they have fewer types of gut bacteria that are colonizing their microbiome. They're getting more exposed to initially the bacteria in the surgical suite than they are in the bacteria in the birth canal. And so there's been some movement towards vaginal seeding, where a doctor places gauze swabs in the mother's vagina during a C-section, and then once the baby is born, it is rubbed with these swabs on its face and body, including the eyes and mouth, with the idea that this will then kind of help kind of create the seeds for the microbiome. However, this is, a controversial practice, and its effects are a little bit unclear and also there's a concern that if there's any vaginal infections, like any strep infections, herpes, chlamydia, gonorrhea, that could all be passed from mother to baby in the vaginal seeding. So obviously something that has to be done carefully and needs more research. In addition, breastfeeding and antibiotic use are also known to alter the gut microbiome. And so mothers who really want to give their baby a healthy microbiome might be better off just focusing on breastfeeding and avoiding kind of unnecessary antibiotics. So this map just shows both the economic and cultural influences on C-section rates. So certainly C-section rates are lower in developing countries, many of whom are on the continent of Africa that don't have access to C-sections. But C-sections also vary among developed countries that have equal access. And so you can see that the US is greater than 30% of births born by C-section, whereas Canada and some parts of Europe have lower rates of C-section, even though they have the technology to do so. So around the world, in more traditional cultures, which means developing and more rural, birth is really the realm of midwives and older women who are there supporting the birth process. And different cultures have different perspectives on birth. Some have more of a celebration of birth, and some have more fear or wariness around birth, and that a woman might be spiritually unclean, and her birth has to take place kind of away from the rest of the community, and maybe she even needs to stay, and that she and the baby need to stay away from the rest of the community for some period of time. So there can be a lot of rituals especially in developing rural cultures around trying to gain some control over what is a scary time. During times that have the potential for death, we often use more practices or rituals that gives us a sense of control. And so we might have special occasions, or we might do some placenta practices that involve burying, burning, or eating, for example. In terms of the placenta eating and encapsulating your placenta, that's something that's even practiced in the US. I believe, here and even in Colorado, you could have your placenta encapsulated and you could eat it. It's believed to help kind of provide additional nutrients and kind of benefits to the person who gave birth. I haven't yet seen any research on it, but it is practiced to kind of get nutrients lost during birth, or it's said that it contains oxytocin, which maybe can decrease bleeding. Placentas can also be donated to research, and I think this was talked about in your textbook. You would have to sign an agreement here in the United States if you wanted to donate your placenta to research. It wouldn't happen without your consent, but I think maybe you read in your textbook about how placentas in other countries might show up in cosmetics, but I don't think that that's happening here in the US. Placentas are typically just disposed of in most hospitals. Okay, so take 3 minutes and watch this video associated with your textbook called How to Ease Pain and Danger During Birth, which shows the birth process around the world, or supporting the birth process around the world. And so, especially in more traditional cultures, we see that there's might be more massage, more herbal teas or medicines, more kind of support, more changing positions, more use, less of a lying on the back position, and more use of an upright position, birthing chairs or squatting, which has been something that we've had to kind of learn in the United States, that maybe it's better to use gravity to help you kind of get the baby out. And there's also symbolic rituals, such as putting a key under the pillow to symbolize opening, or unlocking doors and opening windows, letting animals out, having flowers open. And of course, there's no scientific evidence to suggest that things like this would promote a baby being born, but as we all know, the placebo effect can be very powerful. And so if you believe that opening doors and windows will help you have a baby, then it probably will. So in Western culture, whether that's Europe, Canada, Australia, the United States, we have kind of an interesting history around the birth process. So prior to the 15th century, so Middle Ages and before, midwives were utilized for births and were really respected. And then around the 1400s, and extending for several hundred years, midwives were often associated with witches and were being accused of witches and were seen as more suspect. And so then we had the advent of medical schools in the 1700s, which were just attended by men. And so then they became the perceived experts on childbirth. Unfortunately, however, they weren't really getting great training because it was considered inappropriate to see a woman's genitals, and they might not have even kind of seen a woman's genitals until they first delivered a baby. They also were unaware of germs and kind of the necessity of hand washing. And so doctors might go from basically cadaver dissection straight into childbirth without washing their hands, which led to childbed fever and death for many women. There was also what's called twilight sleep, where women were, and this happened in the 1930s through the 1960s here in the United States, women were strapped to beds and heavily sedated with morphine. So they did experience pain, but they didn't remember it, and they weren't conscious for the birth, for the birth process. So this led to kind of the backlash advocating natural childbirth beginning in the 1960s. There was also the use of forceps, which are like these giant metal salad tongs. And these are still being used today, although more commonly today we now use vacuum extraction, which is basically like a toilet plunger with a vacuum attached to it that you stick on a baby's head to help pull them out. And my son had to be pulled out by vacuum extraction. I was actually born with the use of forceps. And my dad always tells the story that the doctor said, I'm just going to use these forceps and apply gentle pressure on her head while I'm pulling her out. And then my dad said all the veins on his forearms kind of popped out. And I was born with these two horns basically on my head from the forceps that even kind of calcified into bone for a little while before they went away. So the downside of forceps is if people don't really know how to use them, they can cause kind of external or internal brain damage. So in countries like the United States, we're really improving our birth process. And it, of course, depends upon where you are culturally. And I would say just, for example, my experience of giving birth in Indiana 18 years ago was different than my experience giving birth in Colorado 13 years ago. And I had a lot more I was a lot more empowered, for example, in Colorado just a few years later. So it can vary based on the doctor, the hospital, the culture, the period of time. But generally, we are trying to have less of a hierarchical environment, more collaboration, more empowerment of the person giving birth. Fathers and other supportive people are more likely to be able to be involved. But we talk about fathers specifically because, as you may know from watching old movies, the men used to just have to wait in the waiting room with the cigars, and only the women were allowed in the birthing room. And so it's a big shift. And in fact, my dad would not have been allowed to be at my birth in 1972, but because he was a veterinarian, the human doctor said, okay, because you're a veterinary hematologist, we'll just tell the rest of the staff that you're a doctor, and that's how you get to attend. So it's great that we're allowing fathers and supportive people to be more involved during the birth process. And we also are using more electronic fetal monitoring, which is basically a belt that you can put across the pregnant belly to monitor the baby's heart rate. And to also monitor, you can also use processes to monitor contractions. The monitoring of the heart rate is good because it tells us, if a baby's heart rate goes up or down, too low or too high is indicative of distress. But one problem is when you are using something and you don't have a whole history of using it, you can think that something is a bigger deal than it is. But we didn't really know how variable babies' heart rates were. And so some electronic fetal monitoring may have led us to act too quickly with increased interventions, like emergency C-sections or vacuum extraction or forceps that maybe weren't completely necessary. So we also are finding out how much social support decreases pain, and we're going to be talking about, for example, Kangaroo Care and how touch and close physical contact comforts babies, and the same thing is for us as adults throughout our lives. And so having someone who can support us emotionally or physically, whether it's our partners, other family members, midwives, or doulas, decreases the perception of pain. And research has found that women who are accompanied during labor by a supportive person actually use less pain medication than people who don't have that support. And so doulas are becoming increasingly common. And if I were to do things over, especially for my first baby, I would have hired a doula, which basically is someone who's an advocate for you while you're in the hospital, because it's not like doctors and nurses are super busy. Many times you and your partner are in this hospital room all by yourselves. You don't know what you can ask for, what's allowed, what's not, what your options are. And so having someone there who's a real expert to kind of coach you through it, I think is a great idea. Okay, so now let's talk about the neonate, which is a synonym for newborn, which means a baby in its first 1 month of life. So newborns on average are about 20 inches and 7.5 pounds. And when babies are born, they can be covered with vernix and lanugo. Vernix is a cheesy white substance you can see there in the picture that basically prevents the skin from chapping in utero and protects the skin through the birth canal. And lanugo is basically fine, fuzzy, downy hair that sheds within a couple days. Some babies have it, some don't. It's probably something left over from our primate ancestors. Something that people don't often tell you is that babies, both boys and girls, or males and females, are born with really swollen genitals. And so it can be shocking when you look at your newborn baby and you think, oh my gosh, something's wrong there. But it's just associated with the hormones, with the birth process, and their genitals will kind of shrink to a normal size within a couple of days. Babies also have, you've probably heard about these fontanelles or soft spots on either side of their head where the skull hasn't completely fused so that it can squish a little bit as it's coming through the birth canal. And so babies can often have little misshapen, parts of their head that usually even themselves out. Jaundice, many of students talk about having experienced jaundice themselves. It's a yellowing of the skin due to an immature liver and too much bilirubin that's not getting processed. It usually resolves within days or weeks with exposure to phototherapy. We're using that kind of phototherapy more than just sunlight, which used to be kind of what people used. And I'm not sure if they stopped using sunlight because of the risk of sunburn or because it wasn't effective. But now there's kind of phototherapy machines for babies who have jaundice. And breastfeeding can also help process the bilirubin. So the Apgar scale was developed by Virginia Apgar, and you can see that it's got 5 dimensions with the acronym of her name. And then for each dimension, you can have a rating from 0, 1, or 2. So that means that the best possible score a baby could get is a 10, and of course the lowest score would be a 0. The Apgar is usually given twice, once within the first minute and then after 5 minutes. And so this measure has been really helpful, a helpful kind of assessment around the world for deciding how much danger a baby is in and kind of what intervention is required. And so you can see up there, if they get a 7 to 10, then generally we're not so worried about them. But if they're more 4 to 6, then we probably need to get them on some oxygen. And 3 or worse, we might be doing resuscitation or CPR, or any number of things. Okay, so lots of people were born prematurely or low birth weight, and so premature means that you were born preterm, so you did not gestate the full, what they say for pregnancy, 40 weeks, which is actually technically 38 weeks. So you were born before your due date, or you could have been born on your due date, but small for date. And so then if you're preterm or small for date, you're more likely to be low birth weight, and you could be just straight up low birth weight, which is less than 5.5 pounds, or very low birth weight, which is less than 3.3 pounds. And being low birth weight does put you at much higher risk for various challenges and also infant mortality. But of course, lots of people are born low birth weight and go on to thrive in life. So let's talk about infant mortality. Mortality means death in developed countries. And again, remember, most infant mortality is neonatal mortality or newborn mortality, dying, right around the time of birth or shortly thereafter. And what you can see is that compared to other developed countries, we have higher rates. We're not doing so great. And you've probably figured that out by now. You've learned in other classes that even though we think we're pretty awesome here in the US, on a lot of things related to health, we don't do as well as our European nation counterparts. Okay, so this graph also shows mortality rates associated with race and ethnicity. And you can see here that mortality rates in the United States are lowest for Hispanic babies and highest for non-Hispanic Black babies. Mortality rates are overall declining, from 2000, but we can see some disparities there associated with race. So this shows us the causes of infant death associated with different racial or Hispanic origin ethnicity categories. And I've highlighted some kind of numbers there to take note that basically for Black babies, the leading cause of death is that they are premature or low birth weight. There can also be complications in the birth process later, SIDS or accidents. You can see also high rates of congenital birth defects for Native American babies. So in recent years, we've had some particular attention paid to African American mothers in particular, and kind of the disparities in the birth process. And so sometimes people have asked, could it be because of various factors that don't have to do with the color of the skin? So here's some research kind of comparing Black and white mothers in terms of infant mortality rates. And so what you can see here is it's not, it doesn't seem to be related to, it doesn't seem to be explained by marital status, because Black married mothers still have an infant mortality rate that's double that of white married mothers. It also doesn't seem to be something that's just maybe younger Black women giving birth. So you can see that the rates of infant mortality are quite a bit higher, even more than double, if you are an African American woman over the age of 25 as compared to a white woman. And then these charts also show the disparity based on education and prenatal care. So sometimes what people have suggested is, the race disparity could be explained actually by money, that it's about low SES, so less money or less education. But what you can see here is that Black mothers are still, even those with graduate degrees, are still twice as likely compared to white women at similar levels of education to have a baby die. So much higher infant mortality rates, even for more educated African American women. And it's not just about access to prenatal care. So women who don't get access to prenatal care, still among those Black women's babies are more likely to die. So then people have wondered if it was about genetics. And so research has looked at basically when a mother immigrates from an African country, what is her baby's birth weight or risk of, birth weight basically, right after she immigrates compared to later generations. And what you can see there is that babies of African and Caribbean born mothers have babies that weigh more than Black African American babies. Yet their daughters will give birth that are lower birth weight than their own. And we don't see the same trend for European immigrants. Their birth, when they come to the United States, their babies are actually a higher birth weight than the birth weight of their mothers. So it's now being questioned as to whether or not higher rates of Black infant mortality are associated with kind of the cumulative effects of economic and social discrimination. And this is called the weathering hypothesis, that basically Black mothers have a deterioration in their health due to kind of accumulated stress. And Black women do show higher what's called allostatic load, or various biomarkers of stress, things like blood pressure, BMI, cholesterol, compared to white females and males or Black males. And in fact, and it's not just about money, because poor whites have a lower allostatic load than non-poor Blacks. And so there's been a suggestion that perhaps there's toxic stress that is taking its effect on Black women and their ability to have a healthy weight baby that's not so at risk. We don't yet have, this is more of a hypothesis, we don't have clear research kind of indicating this. It could be something more about, the American diet interacting with, racial features, but this is, current thinking. Okay, so Babies are premature or low birth weight for lots of different reasons. In developing countries, this is usually around malnourishment or lack of prenatal care. This also happens in developed countries, and in addition, our primary causes are smoking, harmful substances, or multiple pregnancies. So babies who are preterm or low birth weight often end up in NICU, or neonatal intensive care, where they can get additional warmth because oftentimes they don't have enough body fat to keep themselves warm. They may need additional help with feeding because their sucking reflex might not have come in, might not be strong enough yet, and so they might need to be tube fed. Our lungs are as you remember, the last organ to develop, and they might be to complete development, and they might not be able to easily inflate and take in oxygen, so they might need additional oxygen, or of course different medical treatments or surgeries. In terms of the developmental effects of being preterm or low birth weight, lots of people are and are doing fine, but we will sometimes see some physical or motor delays, so hitting some of those motor milestones later, like sitting up later, or cognitively, kids might be a little slower with language development. They might not perform as well on standardized tests in elementary school. Socially, they might be a little bit slower to do the smiling and the back and forth interacting. I haven't been able to find any research yet, I'm sure it's out there, on how many kids who are born premature or low birth weight kind of outgrow any developmental delays and how many are more persistent. But for those that are more persistent, there's some excellent long-term pediatric services. Some of you may be going into these careers being a pediatric physical therapist or a pediatric occupational therapist, speech therapist, or in schools, individualized education plans. Kangaroo Care we're hearing more about, and it actually emerged in traditional cultures. It started in hospitals in the 1980s in Colombia, and it's now being used in many kind of NICU units around the world and in the United States. And Kangaroo Care is basically just skin-to-skin contact, where the caregiver kind of brings their shirt down so that their chest is exposed, and so that the baby can be, and the baby's clothes are also removed so that they can be placed in direct contact with each other. And what research suggests is that this decreases risks of illness for babies. It stabilizes their heart rate as well as their breathing and oxygen rates. It is better for their body temperature than little incubators are. And it also decreases the expression of pain. So there was a research study done on fathers in Sweden that found that babies who had skin-to-skin contact with their fathers cried less when they were pricked, in the heel of their foot with a needle. Okay, so let's talk about neonatal or newborn reflexes, which are so fun. And these are, reflexive behavior means that it's involuntary. And so babies are born with these, and then these gradually fade over time and then are replaced by voluntary behavior. And so the idea is that babies come into the world with some of these basically predisposed to help ensure their survival. So we've got the rooting reflex, which is where if you stroke a baby's cheek or something touches a baby's cheek, they will turn in that direction, and that's to find like the breast for breastfeeding. The sucking reflex, so babies don't decide whether or not to suck on something that you put in their mouth. They automatically suck and swallow. The Moro reflex is also called the startle reflex, and so if a baby gets surprised or is kind of slipping out of being held, it will throw its arms out and get really stiff. And the thinking behind that is that allows you to catch them a little bit better. You can't catch something that's like limp and floppy, but if they're stiff and they've got their arms out and you can hook it under them, then you can catch them. The grasping reflex, right? You've seen where is if you put your finger into a baby's hand, they will not decide whether to hold on to it. They will automatically hold on to it. And I remember, finding things like that when my kids were little. Like I'd come back and they would still be holding a chapstick, like after 30 minutes. The stepping reflexes, if you hold a baby upright and lower their feet down to a flat surface, they will begin kind of moving their feet in a step-like fashion. If you put them on a little treadmill, moving really slowly, and hold them above it, they won't just let their feet drag. They will try to move them in a stepping pattern. The Babinski reflex is the one where if you stroke the bottom of their feet from heel to toe, their toes flare out. I don't actually know the survival implications for that. And the tonic neck reflex is also called the fencing reflex. And this is where a baby is laying on its back, and it has one arm out and the head turned in that direction. So it looks like they're getting ready to fence, or sword fight. What I think about maybe the survival mechanisms of that is that perhaps that's for kind of regurgitation, that if you're kind of laying with your head and arm out to the side, you're less likely to kind of choke on your own spit up. All right, so of the 5 senses, vision is the least developed for neonates or newborns. And so we're going to talk about the 5 senses here, both primarily in terms of newborns, but with some information on infants in general. So vision, again, is the least developed. Babies can, instead of having 20/20 vision, they have like 2200 or 2600 vision. They are really best at seeing things that are about 8 to 14 inches away, which you may have heard is the distance if you're holding a baby in your arms, kind of if you were kind of in the breastfeeding position, that's the distance they are away from your face. Newborns, again, don't have such poor acuity that they would be categorized as legally blind, but their vision really improves dramatically over the next 6 months. Newborns or neonates don't see color, but they are able to see color around 4 months. But that's why you may have noticed there's black and white and red baby little gems and patterns and things like that you can put on babies' walls, since that's what they prefer, is they can't see colors and they can kind of see high contrast black, white, and red. Interestingly, newborns prefer to look at face-like patterns. So if you made a black and white pattern that was not in the form of a face, and you made another one in the form of a face, a newborn would spend more time gazing at the one in the form of a face. They also actually prefer to look at moving face-like patterns. So if you give them the choice of watching a still face or a moving face, they will choose the moving face. There's also some evidence that in the first week of life, they recognize their mother's face. I don't think there's been research that I've seen yet on fathers. Because their vision is so poor, how they see a face like their mother's face is they basically look at where the hair meets the face, and that's the primary way that they recognize her, is just kind of scanning the outline. And so one thing that I noticed is that after I gave birth to my second child, Iris, I had been wearing my hair down around my face for a couple of days, and she's looking at me a lot. And then on the 3rd or 4th day, I put my hair up in a ponytail, and I could just see that she gazed at me in a little bit more of a kind of questioning way, like, is that still you? Okay, so research says that babies are sensitive fetuses are sensitive to sound, in utero around 26 to 28 weeks gestation. And babies will show, after they're born, they'll show recognition of sounds that they heard kind of repeatedly in utero. So how do we know, what babies recognize as familiar? So you can see this research study here where a baby has headphones where it's listening to different sounds, and it has this pacifier in its mouth that's called a non-nutritive pacifier, which has a cord connected to it, which records how much a bit intensely and the intensity and the frequency of a baby's sucking. And then they play different sounds in a baby's ear, and they look for changes in the pattern of sucking. And so what you could do, for example, is you could play a bunch of different mothers' voices, women's voices, and the baby will show a different kind of sucking pattern for when their own mother's voice comes on than the voice of other women. So that's kind of one example. Or you might play a bunch of different music, and their sucking pattern would change for the music that maybe they most heard in utero. So far, babies aren't showing a strong preference for a father's voice who was present during the time of around the pregnancy experience. Interestingly, babies can also detect differences in speech sounds, amplitude, pitch, and phonemic sounds. And what research says is that babies can hear subtleties in lots of different kind of language sounds that they might not be able to hear later. So prior to 6 months, an American baby listening to Korean or Chinese speech sounds would change their sucking pattern if the speech sound changed subtly in a way that maybe American native English speaking adults wouldn't be able to hear, right? It's a sound that Native Koreans could hear, but Native Americans or Native American speakers could not hear. And so the idea is that babies come in kind of hardwired to learn any language and hear any of its speech sounds, but if they aren't regularly exposed to those speech sounds, eventually after 6 months, those synaptic connections are going to get pruned and they won't be able to detect those subtleties anymore. And so the evidence is kind of mixed about whether or not the baby actually prefers the mother's native language. Some research says that it does, and some research says that it's not quite as strong. So, like hearing, smell is also well developed at birth. Babies prefer the pleasant odors, and they prefer things that smell like their mother. And so how do we know this? You could, for example, take pads that have been in 2 different females' armpits and place them on the side, either side of a baby's head, and look consistently, kind of retest and test and move them back and forth to see which way a baby's head turns. Similarly, you can do that with breast pads that have gotten soaked with mother's milk, and you can put that on either side and notice which way they turn their heads, and kind of move them around and keep checking. Newborns' ability to taste is decently well developed, and newborns can distinguish between sweet, sour, and bitter taste. So how do we know this? You can see the pictures up on the slide. The first one is the baby tasting sweet. The second one is the baby's face after a sour taste, and the third one is the baby's face after a bitter taste. And if you were to repeat these, the baby would make these similar kinds of different faces, which tells us that they are distinguishing between these tastes. Saltiness, or kind of that more savory taste, babies don't have that as newborns. That develops, saltiness, for example, develops more gradually over the first 4 months. We think that babies prefer sweet tasting things, probably because sweet tasting things are safer. Generally, they're not as likely to be poisonous or toxic, and breast milk is also has a sweet taste to it. Touch is also well developed at birth, and when you think about all the reflexes that we talked about, they all require touch sensations. And we also know that fetuses and newborns experience pain, and that's been something that we've recently come to realize in the last several decades. For many years we didn't think that babies could experience pain. Circumcisions, for example, were performed without any anesthetic. But now we realize that babies do experience pain. They just don't present in the same way that older children and adults do. Of course, they don't say ouch. Their cries can be delayed. They often will just go to sleep to kind of protect themselves from pain. But if we actually monitor their heart rate, their blood pressure, their pupil dilation, all that does go up with the experience of pain. And so we've gotten better at doing pain management for fetuses and newborns. Okay, so now let's talk about taking care of newborns. Okay, so historically, breastfeeding has been a very obviously common practice because it was the only common practice. And then we went through a period of time where people were, if they could afford to, they were maybe trying to not be the primary breastfeeders. And so women used wet nurses, and a wet nurse was basically a female who had given birth to her own children, had breastfed them, and had never stopped breastfeeding, and now was hiring herself out to breastfeed other people's babies. And then in the mid 1900s, 1940s or so, here 1950s here in the U.S., we had the onset of formula, and we started to think that formula was a really great thing and better than breast milk, and so then that really caught on. We will talk more about the downsides of formula here in a little bit. But now that we know more about the benefits of breastfeeding, which we're going to talk about, breastfeeding is rising again. It's more common in the United States here for women of higher education and higher income than it is for women of lower SES. So talking a little bit more about the reflexive actions that happen to help promote breastfeeding. So we already talked about the rooting reflex and the sucking reflex and the swallowing reflex. And so for mothers, there's also the milk letdown reflex. And so when a baby is rooting or sucking and when it's time for a feeding, the milk will let down. And it's hard to kind of explain, but basically the milk isn't just always like a faucet, and as soon as the baby starts sucking it, it immediately starts coming out. I don't actually understand how the milk ducts work, but basically there requires kind of some stimulation for the milk to let itself down. And for some females, this is really easy to get the milk to let down, but for other females, it's harder to get the milk to let down, and that's sometimes why people prefer to breastfeed in kind of quiet places where they can relax, because that way the milk will let down. Now in the beginning, when you first start breastfeeding, the milk letdown reflex is not as finely tuned, and it will let down maybe when your baby isn't even feeding, so you're in the middle of target and your milk lets down and can start kind of spurting out and soaking your shirt. And so that's why in the beginning breastfeeding, people have to wear breast pads to soak up any milk that's letting down kind of at the wrong time. Later, your body seems to get more finely tuned to that, and the milk generally doesn't let down unless your baby is actively breastfeeding. It's also just important to know that breastfeeding is incredibly time consuming and can be very painful. So, a doctor told me with my first baby that your nipples will, bleed, scab, and crack, and there's really nothing you can do about it because you can't use medication. So it's pretty painful in the beginning. It's also incredibly time consuming. So babies are very slow eaters. Infants or newborns are very slow eaters. It takes them, whether it's a bottle or the breast, it takes them about 50 minutes to finish a feeding, because they're very slow with the sucking and the solid swallowing movements. They haven't gotten those all figured out. And so what they'll tell you is that the average newborn needs to eat about every 2 to 3 hours. But what they don't tell you is that that's from the start time of a feeding to the next start time of the feeding. It's not a gap in between. So if you feed your baby at 8 and it takes till 8:50, you've basically got an hour and 10 minutes before you start it all again at 10. So it's babies, usually newborns, are eating about 7 to 8 times a day in the beginning. So it's incredibly time consuming and difficult. So this just shows some of the propaganda that was coming out in the 1940s and 50s to suggest that formula could be even better for babies than breast milk. And so again, we swung towards formula for a while, and now we're swinging back because the evidence supports breast milk more than formula. Okay, so now let's talk about the benefits of breastfeeding. At the same time, I also want to just acknowledge that lots of us were not breastfed, and we still have turned out okay. And breastfeeding, again, is challenging. It can be hard to do if you're working. Breast pumping, which we haven't really talked about, isn't always as easy as it sounds. However, though, if breastfeeding can be encouraged, we do want to support and encourage it. Personally and in our workplace policies. So the World Health Organization does now recommend breastfeeding for the first 2 years. That changed actually just in the last several years. It went from 1 year to 2 years. And then, so there's a variety of benefits of breast milk. The colostrum is the very earliest breast milk that is thicker, and it's high in comes out in the first few days after a baby is born. It's higher in carbohydrates, protein, and antibodies. And so through colostrum, and then also just in general through breast milk, babies can, or mothers can, pass along antibodies to any diseases that they've had. It's not the same as getting vaccinated, but it does kind of help provide some protections to the baby. Colostrum also has a mild laxative effect, which helps the baby pass their first stool. They've been building up this poop inside them in utero. It's called meconium, and it's this black tarry poop that's a little bit hard to push out. Some other benefits of breast milk as compared to formula is that it's sterile and at room temperature. And so this is really important for women in developing countries that may not have access to clean water or safe ways to kind of warm up water. And because what happened was, as the formula kind of craze spread to developing nations and women in developing nations started using formula, then we ended up with babies who were getting diarrhea and dying from dehydration due to the formula use. So particularly if clean water isn't available, breastfeeding is really important. There is just this benefit of having it at the right temperature. You don't end up, for example, trying to microwave formula in plastic bottles, which we know isn't a good idea. Breast milk is more digestible and easier on babies' bellies than formula, although there can be challenges with lactose intolerance. It does still provide antibodies, and so it is babies who are breastfed are later on have less kind of diseases and also have decreased likelihood of allergies, so it can decrease your risk of gluten intolerance or celiac disease. Can also decrease your risk of things like ear infections or meningitis, and interestingly also decreases your risk of obesity, perhaps because of the connection between breastfeeding and the microbiome. Okay, so let's talk about crying in the first few months of life. Babies often cry for no apparent reason in the first few months, and this purple acronym kind of describes the pattern. So the peak of it is around 2 months and then begins to decline. It seems kind of unpredictable. We can't figure out the reason. Crying babies you are trying everything you can to do to soothe them, and we're going to talk about that, and it seems to persist. They can look like they're in pain, and you can think that they're in pain, but you can't find anything that's hurting them. Some babies can cry for 30 or 40 minutes, and oftentimes this is happening in the afternoon or the evening. And so we'll be getting into how this is handled culturally and some suggestions for what to do about it, but it can be very challenging. Babies vary. Some babies are kind of low criers, some are medium, some are higher. And so if you have a baby who's kind of a high crier during this time, that's maybe 3 to 4 hours a day for these several month period, that can really challenge your sanity, and you need a lot of extra support during that time and kind of help. We used to think that colic was about kind of GI distress, and you'll see that addressed on the Happiest Baby on the Block video. Now we're starting to think that for some babies it could be, some sort of GI distress. But for a lot of babies, it seems to be associated with kind of being overstimulated or having a hard time calming themselves down. And so when we think about dandelions and orchids, for example, we may have babies who are more orchid-like, who are more kind of reactive and sensitive to their environment. These are the babies that are usually kind of a more irritable temperament. And so they are having a harder time being soothed, is essentially what is one hypothesis that's happening. So babies, really one of their few coping kind of mechanisms when they're upset is crying. And so they cry when they're uncomfortable, they're hot, they're cold, their diaper's wet or poopy, they're hungry, they're lonely, something's pinching them, right, or irritating them. Parents can distinguish how intense the cry is, so they'll know if they're a little upset or a lot of upset. Parents will tell you that they can hear that it's a hungry cry or a tired cry, but if you actually record their child crying and play it back out of context, they can't always tell. So probably what we're doing as parents is we're taking in other clues, like if you're rubbing your eye or if it's about time to eat, then we know that you're hungry or you're tired. But parents can tell how intense the baby is. Crying, as we know, produces a physiological response in the people around you. So if you've been around a crying baby on an airplane, for example, right, it creates this sensation in your body that you want to do something to make the crying stop. You're getting basically more agitated. Your heart rate's going up, your blood pressure's going up, you're sweating. And so this, we have this response to want to help a baby feel better. In terms of soothing, there used to be this kind of belief, especially in the United States, that we had to toughen babies up. We didn't want to reward them for crying by hugging them and soothing them, and which is really, really sad, that they could be spoiled by being comforted, when in fact what the research says is that if you quickly provide physical contact and soothe them, give them the opportunity to suck on a bottle or a breast or a pacifier, and we're going to see some of this in Happiest Baby on the Block, that's your best strategy, and that can really help babies calm down the quickest, and in fact is correlated with less crying over the long term, not more. Okay, so how much crying a baby does depend on culture, interestingly. And in the United States, we have more crying, longer duration, and more intensity. And whether that's because we have a history of less kind of constant physical contact, or we have this sense of individual expression. So in other cultures where babies are kind of carried or swaddled all the time and given on-demand feeding, so as soon as a baby is fussy, then it's immediately allowed to breastfeed, there's a lot less kind of intensity of crying, although of course it can still vary on the baby. So we have been in kind of the United States learning more from more collectivist or more developing cultures about kind of swaddling babies, promptly soothing them, kind of carrying them as a way to support them. Okay, so I hope you'll watch the video clip from the Happiest Baby on the Block, just maybe as much as you have time for. I usually recommend maybe the first 25 minutes so that you can see all 5 S's. So Harvey Karp is an MD pediatrician, and he developed kind of these 5 S's as a way to calm kind of crying babies. And his idea is that if crying is a reflex, we can do some behaviors that can lead to calming as a reflex. There's been a little bit of research on the Happiest Baby on the Block, and what it has found is that parents feel like they can have more skills, they have higher self-efficacy, So they feel like they have more skills to calm their baby. They have more confidence. And so whenever parents feel like they have more skills and confidence, that's a good thing, both for parents and for kids' well-being. And parents who have been taught the happiest baby on the block compared to parents who haven't reported, and swaddling techniques also report that their babies slept about 30 minutes to an hour longer. So swaddling does seem to decrease kind of crying. Okay, so just like it's common for anyone to experience depression, kind of minor depressive symptoms, this can also happen following the birth of a baby. Whether or not you're a biological parent or you're an adoptive parent, it's an incredible transition. And so having the baby blues is kind of the minor version of postpartum depression is really common. Usually it's only around 10 days. It can be as a result of hormone changes or sleep, lack of sleep, or just the enormity of this transition. Postpartum depression is maybe around 10% of U.S. mothers and experience this. Rates around the world vary. Generally, it comes on around in the first month or so after delivery and then can linger for weeks or months. However, some mothers report experiencing it even prior to birth, and postpartum depression also exists in adoptive parents and mothers as well. In order to be diagnosed with postpartum depression, you have to meet the Diagnostic and Statistical Manual criteria for a major depressive disorder, which basically means that you have to have had a depressed mood for most of the day, or a loss of interest and pleasure in most things, most of the day, most every day, for 2 weeks. And additional symptoms are things like insomnia, agitation, a sense of worthlessness, guilt, feeling suicidal. And so it's a kind of higher level of criteria to have a sense of depression most every day, most all of the day for a minimum of 2 weeks. There are also other postpartum disorders like postpartum OCD, postpartum anxiety, and postpartum psychosis. And so psychosis, where you hear those kind of horror stories where a mother drowned her children in the bathtub, those are really a rare kind of co-occurrence with postpartum depression. So what are the possible reasons why a mother might struggle with postpartum depression? So what the risk factors say are, if you have in general a history of depression or a family history of depression, then that can put you more at risk. So experiencing kind of current negative life events around the time of birth, whether that's a job loss or a negative mood or the death of a loved one, can put you more at risk. Having less income and education, which is generally correlated with increased stress, puts you more at risk. And then these ones that are really important here that often get overlooked are around your sense of social support and connection to a partner. So we often think about postpartum depression as occurring kind of biologically within a mother, but there is some very, very strong evidence to show that the more social support and kind of partner support you have, the less postpartum depression you have. So I think it's really important when someone is struggling with postpartum depression to not just think of it as something existing in their biology, but begin to think about how they can not feel so alone in this experience. I remember the first day that my husband tried to go back to work at home, even after our first child was born, and I had to spend like 6 hours by myself, with our newborn, and I remember making it like about 6 hours before I came in to his office, just his home office, just crying like, I can't do this. I need to feel like we're a team, right? And unfortunately in our society, we put so much pressure on mothers to know how to do everything that mothers can kind of take that on and often, don't feel like they have kind of the support they need. They feel like it's all up to them. So important to attend to that. And of course, if we have there's a lot of research that's set on maternal depression, more than has been done on father depression. But there are, for having a depressed mom, generally it's harder to be as sensitive and responsive to a baby, and so then the baby is more at risk for irritability, difficulty feeding, challenges with sleep, and an insecure attachment. Now, some of these things are correlates, like irritability and feeding. It could be that these things are making it harder for a mom to care for a baby and making her more depressed, and then she's not as able to respond to as well, and then that kind of becomes a cyclical interaction. Okay, so as I mentioned, most research into postpartum depression has been done on mothers, not fathers, but there is more research coming on paternal postpartum depression, and it has also been shown to have negative effects on the family and on kids. And so one research study, for example, that was longitudinal, found that having a father who was depressed when you were an infant was correlated with you, if you were a female, developing depression yourself as an adolescent, or kind of acting out behaviors in kids in elementary school. It's also associated with increases in the conflict in the couple relationship. What are the risk factors? It is highly comorbid or co-occurring with maternal postpartum depression. So if you've got a mother who's stressed, then in a heterosexual couple, then you often have or depressed, then you often have a father who's also depressed. And so that could be because they are kind of unable to support each other and kind of, feeding off of each other. It could also be because they're experiencing the same kind of negative life events and lack of social support. So some of the very same predictors and some of the same kind of risks to infants in terms of attachment insecurity.